Welcome everyone to this session. The title is A Dedicated TAVI Device for Aortic Regurgitation, the JWAF Solution. Today, I'm happy to be the anchor person. I'm Simon, and we also have Doming Hao as our spokesperson, and we have the distinguished panel. We have Michael, and also we have Professor Wei Lai. So first of all, we'd like to have an overview of the learning objective, which includes to learn the 30-day outcomes of a novel transfemoral TAVI system with a special anchoring mechanism for aortic regurgitation. And we also will want to learn the 10-year outcome of a novel transapical TAVI device for aortic regurgitation. Third, we also want to know how a novel TAVI device with automated anchoring mechanism for aortic regurgitation works and help our patients. So first, we'd like to invite Professor Lai Wei to share with us the 30-day outcomes of the JWAF transfemoral system.
Thank you all the specs audience. I'm Lai Wei. I'm a cardiac surgeon from Zhongshan Hospital, Shanghai, China. So on behalf of the JWAF TF China investigators to report our 30 days outcome of transfemoral JWAF for chronic aortic regurgitation. It's a prospective multi-center study in 127 cases. It's my conflict. So first of all, let's introduce some background for the aortic regurgitation. This kind of patient is no calcification of the leaflet of the annulus, lack of anchoring area, and the root and the annulus always dilate. So it's difficult to anchoring the THV to the sinus. So it's a big challenge. But as to the prognosis of severe symptomatic aortic regurgitation, if the patient, the New York Association, the heart function is lower, the mortality is over 70% at 5 years. This is the JWAF TF system for aortic regurgitation. Two components. The left one is the valve, and the right one is the delivery system. The leaflet of the JWAF TF is pulling pericardium, and the most important part of the stent is the anchor ring, and the valve where depend on the anchor ring can securely positioned in the 3 sinus. And this is the video. You can see that the yellow knob control the anchor ring into the 3 sinus, and the gray knob control the valve and the opening and the position, delivery system. Our trial purpose is to evaluate the effectiveness and safety of the JWAF TF system amongst the patient with symptomatic severe aortic regurgitation who are high risk or inoperable for surgical AVR. And the trial design is a prospective multicenter single-arm evaluation of patients with symptomatic aortic regurgitation, severe or moderate to severe patient for high risk or inoperable. We will follow up the patient at 30 days, 6 months, 1 year, and annual up to 5 years for clinical and echo and quality of life. They are the PIs of the enrolling sites, totally 18 medical center in mainland China. They are all the investigators and trial sites. The key inclusion and exclusion criteria is, for example, the age is more than 65 years old, and the symptomatic moderate to severe or severe AR patient, high risk or inoperable, and so on. The primary endpoint is the all-cause mortality at 12 months, include cardiovascular mortality and non-cardiovascular mortality. The key secondary endpoints include the cardiovascular mortality, pacemaker rate, hemodynamic valve performance, and ARV remodeling, the functional improvement of the heart and the quality of life. Each patient is reviewed and accepted by the multidisciplinary heart team, and 100% CEC justification of all serious adverse events. The 5 years clinical and echo follow-up for all patients. Totally 127 patients enrolled in the clinical trial, and 124 patients successfully implanted the J-valve TF system. Only 3 converted to surgical. And the 30 days follow-up, 100%, and we are still going the 1 year follow-up. It's the baseline patient characteristics. The average the age of the patient is 74 years old, and the mean ST score is 6.1, and the 74 patient is New York Heart Association class 3 or 4, and so on. The baseline echo characteristic include that nearly 80% of the patient is severe aortic regurgitation, and the 21% are moderate to severe. And the pure no calcification AR patient is about 89%. Only 12 patients have very mild aortic stenosis, and the venous contractor width is 7.5 millimeter, and the mean gradient is 13. Yes. The leaflet, the most of the patient is tricuspid. 96% of the patient is tricuspid, and 3.9 patient bicuspid and quadricuspid, and the parameter of the annulus is the mean parameter is 81 millimeter, and about 61% is over 80 millimeter. Most of the patients no calcification both on the leaflet or the annulus. The left coronary artery height, the average is 12.8, and the smallest the height is only 4.3 millimeter, and the mean annulus angle is 55.5, and about 10% is horizontal aorta is the degree is over 70 degree. The procedure details. The device time is only no more than 20 minutes, and most of the valve is medium or large. The procedure outcome, no in-procedure death, no stroke, no acute myocardial infarction, no main bleeding, acute kidney injury. Only 3 patients, 2.4% converted to surgical aortic valve replacement, and only 3.9 need a second valve, and the coronary obstruction 0, and the femoral access site repair is only 1 patient, 0.8%. The procedure outcome, the valve thrombosis is 0, and the mitral damage 0, and so on. And totally the technical success, according to the definition of VAC 3, is 93.7%. 30 days safety outcome, the all-cause mortality is 1.6%, include one patient died because of the ascending aorta dissection, and another patient died of the reason is unknown at home. The new pacemaker rate is 9.5% at 30 days, and the major vascular complication is only one patient, 0.8, because of the died patient. The myocardial infarction 0, stroke 0, major bleeding 0, and acute kidney injury is 0. The safety composite endpoint is 16.5%. The hemodynamic valve performance include the mean gradient. 30 days is 7.4, and the EOA is 2.1 millimeter square. The power valve leak, 76% of patient is only none or trace leak, and 23% patient is mild, and only 0.8% is moderate leak, no severe leak. The left ventricle remodeling, the left ventricle and the left ventricle size both are systolic, diastolic is reduced, and the New York Heart Association quality of life improved 30 days. So we can draw the conclusion that the J-valve transfemoral system have demonstrated the following characters in AR patient: has low mortality and morbidity at 30 days, low new pacemaker rate, and excellent hemodynamic valve performance, and echo shows that a significant improvement in ARV remodeling and a significant clinical functional improvement. We will thank all the investigators and all the sponsors and all the patients, the CEC members, and so on. Thank you all.
Thank you, Professor Wei, on this sharing and the fantastic results on the transfemoral system for treating patients with aortic regurgitation. So I'd like to ask for any comments, and we can go across the table, and maybe Domain, can you have some comments?
Yeah. First of all, thank you, Professor Wei, and reported 30 days, such nice, dedicated devices for pure AR result. And I do receive a couple of questions from audience, and I can go from there. So the first question, audience asked, when the 1 year, you mentioned that 1 year we reported, now 30 days already finished. The question is when the 1 year follow-up result is expected, and where you will planning to target, which conference you will report this one.
Okay. Yes. Yes, we have finished the 1 year follow-up, and the data. We plan to show the 1 year data the next year PCR in Paris. So I wish all of you can. We know that the result is very good, and we all expect the next year, maybe May in Paris.
Thanks, Professor Wei. And clearly, we all know there are two dedicated devices, and presented in this London Valve, and I think a lot of physicians already know the devices. Clearly, when you see the pacemaker rate and the J-valve is really dramatic. You see that decrease, compared to comparators. Clearly many factors maybe infect that. I just ask, Professor Wei, what's your opinion? Why the J-valve can achieve such low, lower than single digits, right? pacemaker rate?
Yes, the pacemaker rate is I think is the most important advantage of the J-valve TF system. Actually, in the beginning of our clinical trial, the rate is relatively high. And in the end part of our clinical trial, the rate is significantly decreased because of we accumulated many experience. We don't need to oversize to choose a bigger valve to oversize, and we only need 5% or mostly we around 5% oversize. Some patients maybe 10, so 5 to 10% oversize is enough for the regurgitation patient. And so in the second stage, if we can separate our clinical trial to two different stage, and in the second stage we can decrease the rate, the pacemaker rate to about 5%. So another evidence is that the transapical J valve, we have used the transapical one for about 10 years, and then the pacemaker rate only 3 to 4 to 5%. The transapical version of J-valve. Okay.
Yeah. So can I ask, Michael, you have a lot of experience on treating AR with different devices. You have experience on another types in the system as well, and also previously non-dedicated device. So any specific insights or new things that you pick up from this study once when Professor Wei Lai presented data?
Yeah. First of all, this is a study which show excellent outcome results. Bearing in mind that a lot of your patients are actually complex patients. 2/3, I think it's about 2/3 of patients is having big annuli, more than 82 mm. And some of these are having short left main as well. So that would be expected to have a lot more complications than you have just shown. So I think the results are very encouraging for us to see. I just want to ask, although Dongming is going to present the transapical version later on, do you see a difference in the outcomes between transfemoral and transapical? Although you have been doing transapical for longer, more patients in China as compared to transfemoral, but are the results comparable?
Yes, maybe we will have the 10 years outcome of transapical J-valve, and yes, compared with the transfemoral and the transapical, because of the transapical version still have a damage to the apex. So I believe that the transfemoral one will have the more excellent result for the patient recovery and the long-term result. And this is the first reason. The second one is the biggest transapical version J-valve is only 29. But the TF, we have 34 millimeter. So in transapical version, we can only kill the parameter no more than 90 or 95. If the patient parameter, annulus parameter is over 95, the transapical version of J-valve will not the malposition, but there will be a leak. But if we choose a bigger transfemoral one, and the leak will disappear. So I think the result will be better.
Yeah, this is what I want to ask, because for the other device that we have been using, we can't really treat very big annulus. For your device, how big? What's the biggest annulus you have?
Yes.
Yes.
The biggest transfemoral the version is the diameter is 34. So the patient, we can treat the diameter 24 or 25, I think is okay. So in our clinical trial, the biggest annulus parameter is 113.
Oh, that's big.
Yeah, it's very big, very big.
And you showed about 1%, although it's very low, moderate PVR at the end. Why would there would be a moderate PVR?
Sorry.
The paravalvular leak.
Yes.
But moderate is about.
It's a
I
moderate,
think it's about
yes, yeah.
1%.
Yes, only one patient.
Cause? What's the cause of that moderate?
It's not in our in my center, so I can only draw from the data. I think maybe we choose a smaller one. Maybe I think to afraid that maybe it's a pacemaker rate. So
Yeah, but then I think overall the data is reassures the safety and efficacy. And I think there's no anatomical exclusion for complex anatomy, horizontal aorta, extra large annulus. So I think we can move forward to looking at the data for our experience with transapical systems. So thank you for the discussion. And now I would like to invite Domain to share with us the 10-year outcomes of transapical. Professor Gao is online.
Yeah.
Okay.
Yeah.
So it will be by Professor Gao.
By recorded video.
By recorded, yes.
Yeah.
Okay.
Can you
Can you show the recorded lecture?
Yeah, recorded presentation. Again, so many questions, and we'll get some time to answer those.
Yeah.
10 years outcomes of transapical J-valve system for both aortic regurgitation and aortic stenosis. This study represents a decade of research and collaboration by the J-valve transapical investigators. I don't have any conflict of interest to report. And the J-valve transapical is an innovative TAVI device. It's self-expanding with a low-profile frame and uses the porcelain valve leaflet. What sets it apart is its patented accurate ring design, which provides secure positioning in both calcified and non-calcified anatomies. Importantly, it's the only National Medical Products Administration approved TAVI device for the treating both aortic regurgitation and aortic stenosis. Let's take a quick look at the timeline. Our journey began at 2014 with the first patient enrolled in China. By 2019, we had released the 5-year outcomes, followed by the 8-year results in the 2021. And now, 2024, we have presented the 10 years data. This result proved one of the most comprehensive long-term evaluation of a TAVI device, underscoring the durability and efficiency of the J-valve system. The slide outlines the procedure steps for the J-valve transapical implantation. After apical access is established, the delivery system enters the heart following the guide wire. When the valve reaches the intended position, open control knob 1. The slide outlines the procedure steps for the J-valve transapical implantation. After apical access is established, the delivery system enters the heart following the guide wire. When the valve reaches the intended position, open control knob 1. The anchor ring springs open. Pull back the delivery system to ensure the anchor rings are locked onto the native aortic sinus. Turn control knob 2 to place the valve at the position of the native aortic valve. Turn control knob 3 to release the valve. Verify that the stent has fully expanded and access is positioning. Once the valve is correctly positioned, restore control knob 3 back to its original position. Then turn the release control knob to complete release and the valve from the delivery system. After the anchor ring is completely released, pull the delivery system back out. Restore the control knob 2 to its original position. And then gradually restore the control knob 1 to its original position. Ensure that all knobs are reset and then deliver the heart. ensure that all knobs are reset, and then the delivery device exists at the heart. This was a prospective multi-center cohort trial to evaluate the long-term safety and efficiency of the J-valve transepic system. We enrolled 107 patients across 3 centers in China. These patients underwent J-valve implantation between 2014 and 2015. Follow-ups were conducted at 12 months, 5 years, and now 10 years. The primary endpoint was the concomitant all-cause mortality. To ensure the comprehensive data collection, we set up a detailed schedule of assessments. A total of 107 high-risk patients underwent transepic aortic valve implantation with the J-valve transepic from March 2014 to July 2015, which included 64 aortic stenosis patients and 43 aortic regurgitation patients. All patients were symptomatic, and over 95% people patients with New York class 3 or 4 heart function. By 12 months, overall mortality was 5.6%. Subgroup mortality was 4.7% for aortic regurgitation patients and 6.3% for aortic regurgitation, aortic stenosis. The permanent pacemaker rate at 1 year was 4.7%, which is much lower than other TAVI device. Our follow-up rate at 10 years impressive 19.7%. The mean follow-up duration was over 115 months. By this time, the average patient's age was 84.3 years old. At 10 years, the overall all-cause mortality rate was 34.2%. When we split this by disease type, aortic stenosis patients have a mortality rate is 27.6%, and significantly lower than the 44.1% observed in aortic regurgitation patients. The different highlights the challenges in managing aortic regurgitation. When we compare our aortic stenosis group to other TAVI devices, the J-valve rarely stands out. It has a significantly low 10 years mortality rate. This finding emphasizes the J-valve transepic system's strong performance in patients with aortic stenosis, even over an extended follow-up period. The slide outlines the cause of the death in all patients. Of which 20 patients died of cardiovascular reasons, and 12 patients died of non-cardiovascular reasons. At 10 years, 9.35% of patients had a stroke, which is interestingly even lower than the blue curve that drives the stroke rate in healthy Chinese population of the same age. At 10 years, 11 patients, or about 1.3%, required a pacemaker. The rate was a little bit higher in aortic regurgitation patients at 11.6%, compared to 9.4% in aortic stenosis patients. These rates are still quite favorable when compared to the other TAVI device systems. The calculated rate of the valve intervention over 10 years was just 3.7%. This low rate reflects the durability of the J-valve and its ability to provide sustained hemodynamic performance without significant deterioration. We collected echocardiography data of 51 patients at 10 years. What's especially impressive is that 19.9% of aortic regurgitation patients had complete echocardiography follow-up at 10 years, showing consistently excellent valve function. We evaluated prosthetic valve hemodynamics for patients with aortic regurgitation at 10 years. The mean EOA was 1.5 centimeter score, and the mean gradient was only 14.1 millimeter mercury. Similarly, in aortic stenosis patients, the valve maintained excellent hemodynamics at 10 years. The mean EOA was 1.8 centimeter score, and the mean gradient was 14.2 millimeter mercury. Both were within acceptable ranges for the long-term valve performance. Prosthetic valve function remained excellent in both groups. At 10 years, no patient in follow-up had moderate or severe prevalvular leak in aortic regurgitation. In aortic stenosis group, 3.8% patients had moderate PVL and 3.8 patients had severe PVL. For aortic regurgitation patients, significantly LV remodeling was observed post-implantation. Paired analysis showed evidence of left ventricular remodeling. Mean LVEDD declined from 60.5 millimeter at baseline to 47.8 millimeter at 10 years. The mean LVESD decreased from 42.1 millimeter at baseline to 32.5 millimeter at 10 years. This result demonstrating improved cardiac function following J-valve implantation. Aortic stenosis also showed left ventricular remodeling. Mean LVEDD declined from 41.6 millimeter at baseline to 47.4 millimeter at 10 years, and the mean LVESD decreased from 35.3 millimeter at baseline to 30.6 millimeter at 10 years. This change reflects the positive impact of the J-valve on cardiac death. Lastly, we evaluated the New York class for both aortic stenosis and aortic regurgitation patients. Significant improvement in function status was noted. At 10 years, for aortic regurgitation patients, New York function class status was class 1 in 47.6% patients, and the class 2 in 47.6 patients, and the class 3 in only 4.8% patients. In other way, for aortic stenosis patients at 10 years and at 10 years, and 64.5% patients were class 1, and the 32.3% patients were class 2, and the class 3 in only and the class 3 in 3.2% patients. In summary, the 10 years outcomes of transapical J-valve system demonstrated its safety, efficiency, and durability. It's a reliable solution for the high-risk patients with aortic regurgitation and stenosis, offering the sustained benefits over the long term. Thank you for your attention.
So now it's open for discussion again. So it appears that 10 years durability is still very fantastic. But usually we anticipate for other prosthetic valve, then they may have proto-degeneration, but it appears that it works well even after 10 years. And do we know about the aortic dilatation that, throughout the 10 years, would there be changes in dilatation, progression? Do we know about the data on that?
That's a very good
because
question.
sometimes for treating AR is different because we take the aortic dilatation as one of the key factors whether we go for surgery, because otherwise they may need to replace the root. And throughout that 10 years, if the patient had some degree of dilatation to start with, after 10 years later on, what happens to the dilatation? Would it slow down, or it is independently enlarging?
Yes, we have if the patient ascending aorta dilation is the diameter is more than 50 millimeter, usually we will choose surgical replacement. So if the patient the diameter is only no more than 45 millimeter, because we are all cardiac surgeon. If the patient diameter is no more than 45, I don't think it were necessary to replace the ascending aorta when we, especially the patient is tricuspid valve. We don't need to replace the ascending aorta. And in our follow-up, I cannot remember in our hospital. I have no even one patient need a surgical intervention, both for the aortic valve or for the ascending aorta. So I don't think it's need to concern about the patient diameter is no more than 45.
Yeah, and also think that for treating AS, sometimes the frame, TAVI valve are not well expanded. But all these valves, because there's lack of calcium, they are well expanded. Hemodynamic is brilliant. I think that also contribute to better durability.
Yes, correct.
Yeah.
Clearly, it's good hemodynamic, good after valve change, the shear stretch all change, maybe can moderate the aortopathy at this perspective. You know, several questions, and one of the questions asked also concerned the pacemaker rate. You know, from this 10 years report, you know, re-emphasized, you know, quite similar to transfemoral version, because transfemoral version even 30 days 9.5, 9.3 range, yes. But you know, transapical version even lower than 5, than 5%, which means such many patients already confirmed the pacemaker rate is really not a big concern for this, you know, based on the data set.
But right. Why is transapical actually better than transfemoral?
I think the surgeons, they're smart.
Yes, I think, but no, I think because because most of the clinical trial of the transfemoral version is cardiac surgeon in China. So we are not very experienced with the transcatheter skill technique. So usually we will put a large, big valve at the beginning of the clinical trial. So as I just mentioned, that in the last part of the clinical trial, the rate is reduced.
And I noticed that from a TA cohort involve both AS and AR patients, and for the transfemoral JValve is only include AR. So is it the move that we may also want to see how it works for our patients with AS? Because certainly we have patients with low coronaries, we need absolute commissural alignments, and you can see also 4.7 pacemaker rate for those patients. So what is the plan upcoming for research? Would also include cohorts for AS?
Yes, the company is planning to clinical trial in AS, but now they are focused on the regurgitation patient, because there are many devices for the AS, so maybe they were focused. Yes.
So I think AR is unmet need nowadays.
Yes.
Right.
So thank you very much. We move forward to the record case on JValve will be shared by Doming.
Just to clear one thing, because the transapical version is already on market in China for both indications, AR, AS. Transfemoral now we're doing the AR version, right? It's in the future. So again, thank you for the invitation. My task is a case report, a transfemoral version of JValve. This is my disclosure. So as Professor Wei showed earlier, in his presentation, you can see this valve is a U-shaped 3 anchor ring and one pericardial leaflet, and it's clearly, you know, because it's anchor ring, you can, you know, very well preserve coronary regarding the high and also very well commissural alignment. You can see when you do the deploy, if you pay attention to this small video, you can see it's auto-adjust. When the U-shaped anchor ring attached commissure, the coarctation line will be smaller adjustment, allow the anchoring automatically go into the sinus if you have good trajectory. So this is a patient did by Professor Guoying Qiang, earlier presenter. The patient is a symptomatic severe aortic regurgitation patient. The man, 72 years old, chest tightness and shortness of the breath for 6 months, hypertension, unstable angina, and MIHA4, STS score 9.4. You can see from the echo, vena contracta is 9 millimeter. Here's the CT, and you can see, particularly I needed to emphasize here, this is routine normal cases, right? It's a relatively big parameter, as I say. You know, we all know the Trilogy Jana trial, you know, if you have a more than 85 millimeter parameter, it was an exclusion criteria. For this, you know, they can cover pretty large parameters. The largest, like Professor Wei said, 34 valve you can cover, you know, indicated by manufacturer is 104 parameter. So this is a dual treatment, that part of patient. So you can see that this is LVOT, this is a measurement standard valve. Clearly, it's no calcification. It's purified aortic regurgitation. And here I will draw your attention, the membrane septum is really, really short, 3.5 millimeter, and no calcified, only slightly tiny in the great vessel. So this is a procedure. Follow the routine procedure. In the implanted valve always use the coplanar view, and you can see this is root aortograph. You can see great regurgitation, and then this is recommended use the Safari wire, the best wire, and also you can see the pressure gradient. This is the pressure, the pulse pressure, right? The pretty low diastolic. This is a wire going to there, and it's very common procedure because this kind of aortic regurgitation patient, you can as long as the valve go there, like a spacer, the hemodynamic make it really stable. This is a valve going to the out of the sheaths, and the 28 millimeter valve, and across the aortic arch, very, very smoothly because there's two component. Very. By the way, the valve can deflect to 260. You can sterilize the valve. Now you can see he's focused on the yellow and the gray knob. He's moving the anchoring out of the delivery system. They call delivery devices, and then they push the yellow knob. It's just the knob, yellow gray knob interaction, and then you can push the yellow knob, go down. You can see the anchoring slowly, drop to the coronary sinus. Now he move out the pigtail to prevent the interaction, and then you can see the one shot easily to go to the 3 cuspes. Again, this is a coplanar view. And then this is a valve frame. He will do a maneuver which is locking the valve and anchoring relationship. This is very, very necessary, very, very, very important step. As long as you see this kind of sign, which means the stent frame is well locked with the anchoring, the relationship. Now he will push the gray knob. You don't need rotation. You just come down like an automatic car. You do, and then to the particular position, and then he will start fast pacing. He will check the position final time. He move the pigtail, going. If you are not satisfied the position, you can still push the whole devices going to the sinus, and then he will drop down the pigtail, doing the final check. And then make sure all the U-shape anchoring stay in the coronary sinus, because he found that non-cuspus slightly higher. Just to push the whole device, holding the yellow and the gray knob together slightly, and then push down. You can see changed because this is a little horizontal. Although CT is not, I will say a little horizontal. Now you can fix the position. He first, centralize, withdraw the support wire, and further, make sure the position is right. It's already a shot. And then tugging lock the two knob, yellow knob or gray knob. And then at this moment, you cannot move. And then fast pacing, you release the device. You just, slightly maneuver the wire. You can centralize the valve. You can see the trajectory really good. And then just counterclock, rotation the gray knob. It's under the fast pacing, okay, because you have high pulse pressure. The valve release, and then it's a sequentially release step. And then you can see if you release the yellow knob, which means is control the U-shape anchor ring, and then just turn, half turn, and then it's released. Now it's to follow the sequential, move the yellow and the gray together to withdraw the connection cable. The connection cable is falling down. Apologize because I'm here. I'm looking very clearly. So definitely you need to be cautious. Sometimes you need to really carefully detach with the U-shape anchor ring. But now all three connection cable detached. I said the echographer is really excited. Early push the probe down. But anyway, you see here already really good. No PVL, very good, valve function here. But anyway, also you can pay attention to EKG. No change at all from very beginning to the end. QRIS very very narrowing. And now carefully move the nose cone. Withdraw the nose cone, I'm sorry. And then you do the final shot. Let's see what's it look like. I wish it will be a good one. So, okay, now follow the sequence. Move the delivered device out, and then switch to the pigtail, measure the pressure, and also do the inject. You can see the diastolic already, but now it's still not, because you will see afterwards. Here, it's definitely no EKG change. But keep in mind, at the very beginning, the systolic is low, it's 100. Right? Now it's final shot. No PVL, very good valve function, well positioned, and no conduction system impact. Even short membrane of septum. Clearly, this is auto-aligned, commercial aligned, and for future, you still can have a room to do the lifetime management. And this video is done. And then this patient symptom released in MIHA class from 4 to 1 and 2 during follow-up. No PVL. EOA is 2.1. I think it's big enough. Mean grading 8. And then I just want to recap the deliver steps. Let me play this. Just another 1 minute. Basically, it's like it's like an auto car. If you're driving, you have a car racing class. You have a low car. In general, it's pretty easy. Regardless how you do that, you do the coronary, you do the aortic angiogram, and then you move the anchoring down, and the anchoring going engage the sinus. You don't need to see, just use coplanar view. Definitely you can use overlapping view to double check, but this is good enough. And then basically you can see the gray yellow knob, but here is transparent knob. This knob can allow you to do the deflection. It's the maximum based on the tortuosity of anatomy. You can do 260. It's a flexible, very flexible delivery system. And then just this sequential. Keep in mind this yellow and the gray relationship, and then you final double check, Clearly you can use a multi-purpose catheter. Each sinus check, that's also is okay if patient renal function is okay. And then final release. This is basically follow this. And this is, regardless, this is horizontal, like almost more than 80. It's American compassionate case. And this is another big valve, 34. That's pretty good. Thank you for your attention.
Thank you very much, Doming, sharing with us the case. I can see that even if a horizontal aorta, or you can adjust, actually it goes, as you said, it's an auto car. You manipulate the steering ability and the bowing of the attention between the two knobs. It gradually goes to that angulation without extra push to a particular sinus, getting leaflet stress. So I think it works quite well. And my second question is, I see that from the study and also in your case, is you're also using TEE as a must for the procedure. Is it the trend we still need TEE for this procedure of JWAF, or we can move away just like ordinary TAVI?
I will allow Professor Wei has his opinion.
Yes, a good question. I have tried the total TEE for the transapical. The J-valve have 10 cases. All the 10 cases is successful and no mortality, it's a very good result. And but the transfemoral one, we don't try it because of the clinical trial. We will be safe. But I believe that we can do the total TE. After commercial use. Okay.
And sometimes from TE, we can see the sinuses. We can identify the crispus.
Yes. It's not necessary. I totally agree, because I agree with Professor Wei. It's not necessary because it's trial cases, right? We are now doing the trial. This case is typical case. There, without local anesthesia, deep sedation still work. Yeah, but and then because you can use TE to see the going to sinus. Also, you can use pigtail, multipurpose to see which one going. True. And based on shape.
You have a lot of bicuspid valve in China. Have you treated bicuspid AR?
Yes. The TF we didn't try, but the TA we have tried. Yeah. Yes, honestly, it's not very suitable for the pure no calcification AR, bicuspid AR, use J-valve because the anchor ring is a U shape and 3U. So maybe it's not very comfortable to stand in the two sinus. But we have tried. And most of the case, we have get a successful result. But the result, but yes, seldom we failed, and the valve gone. So I don't strongly recommend that if you don't have experience for the J-valve, you are not try the pure AR bicuspid case. But if you have many experience, I think maybe you can try.
By the way, in the trial, they have about 3%, 3.5%, 3.5% bicuspid and quadricuspid. But if you have type 0, it's different story. Yeah. Type 1, we are not propaganda, but if you have type 1, you have 3 cuspes, still doable from the business.
Yes, especially the type 0 is very, it's a little different, dangerous. Okay.
I see a question. Go ahead.
Yeah, about some technical. So in both the transfemoral and the transapical video, it seems that just seconds prior to valve release, the heart rate went up. Was rapid pacing used, or was it not? And if it's rapid pacing is used, how do you decide when to use it and when not to use it? Is the Yana valve, does it need rapid pacing?
In the early U.S. trial, we don't need rapid pacing, but in China trial, we do recommend to do rapid because the pulse pressure sometimes, they play some role. So you need to see the pulse pressure, and from safety side, if you do the rapid pacing, definitely help.
I think in the
More
instruction
accurate.
we use actually not required mandatory.
Yeah,
But
a lot
I-
of valve you can release without.
but I think in patients with
but-
poor airway function, you can skip that, or some controlled pacing
Exactly.
up to 140. I think is
exactly,
good enough.
Exactly.
But when we look at your 10-year mortality, I think it was 44% for AR and 24% for AS. Why is there a difference?
I think maybe yes, the stenosis case. I think if we expand the stenosis, the patient will benefit well. But the regurgitation patient, maybe the etiology is quite complex. Okay.
Yeah, they still have many questions. I know everybody interested. Definitely from my limited experience, really great valve. You can, like a car driver, you have different level. Professor Wei, definitely high level, have many procedures in hand, both surgery and transpercutaneous. But when you're handling this couple of knob, you don't need a rotation. You just come down, lay on the table, play this sequentially, yellow, gray, remember that, and you do that. Majority cases you can finish.
So I think we have a very fruitful discussion today, and also with the recorded case and also the lecture. And congratulates once again for TF J-valve data to be put up in a late-breaking trial, which reassures the safety and efficacy of the procedure. And in the past, AR cannot be treated. Now we not just want to treat it, but we use dedicated device, advanced device, just like having a TF system or TA system with J-valve. So thank you once again for coming, and special thanks to people behind working on the innovations, research works, clinicians, and also supporter with for this session, Genesis MedTech. So thank you very much for joining, and thank you, and enjoy the rest of the day.
Thank you.
Thanks.